Hello. In this session, we shall discuss bleeding and coagulation disorders which may affect your patients as a dental therapist or hygienist. Uh, this session would be recorded as a PowerPoint show, which means that you would be able to view each slide and listen to the associated audio recording with each slide, and then click to move on to the next slide, and you can always move back. So that's how you would view this presentation. The aims of this session are to provide the DTH students with an understanding of medical disorders associated with increased risk of bleeding, and by the end of the session you should be able to discuss increased risk of bleeding in relation to bleeding disorders, coagulation disorders, and medications which the patient may have been prescribed by their GP. You would know from your physiology knowledge that hemostasis is the arrest of bleeding and is classically described in three stages: primary, secondary, and tertiary hemostasis. Primary hemostasis is initiated immediately following blood vessel injury and involves two mechanisms. First is the blood vessel contraction, particularly the arterial vessels, they contract to limit the loss of blood. Simultaneously, uh, there is formation of the platelet plug, uh, which involves adhesion of the platelets to the damaged subendothelial tissues, specifically collagen, um, activation and aggregation. So that leads to the formation of a platelet plug, which causes initial arrest of bleeding. However, it needs to be stabilized through activation of the clotting cascade. So that constitutes secondary hemostasis. Activation of the clotting cascade, which we shall discuss in a bit more detail in the next slides, leads to deposition and stabilization of fibrin, which is the definitive blood clot. Now, at a later stage, to prevent thromboembolic disease, the blood clot undergoes dissolution. So dissolution of the fibrin clot is what we call tertiary hemostasis and is dependent on activation of the plasminogen. It may be a good idea for you to familiarize yourself with various blood coagulation factors. Uh, I've provided the table here. I'm not going to read out everything, but just highlight the main bits. So for example, factor 1 is fibrinogen, which is one of the plasma proteins, and activation of fibrinogen is what leads to the formation of a blood clot. So it's basically fibrinogen which polymerizes to form a blood clot. And you would also note that factor 13 is the fibrin stabilizing factor, which actually polymerizes activated fibrinogen into a polymerized fibrin and stabilizes the blood clot. So you can read about all these factors and their function and genetic disorders associated with specific blood coagulation factors. And you would also note that apart from the 13 procoagulant factors, there are also anticoagulant factors within the blood: antithrombin 3, heparin cofactor, protein C, protein S, and plasminogen, which create a balance of procoagulant and anticoagulant activity in the blood, which is part of the internal homeostasis of the body. This image depicts the uh, mechanisms of hemostasis. Following blood vessel injury, there is a neural response immediately, which leads to blood vessel constriction, reducing the blood flow and reducing the loss of blood. Simultaneously, platelet plug formation takes place and provides initial hemostasis. And this platelet plug is further stabilized through activation of the clotting cascade, which leads to uh, activation and deposition of fibrin, which constitutes the stable hemostatic plug. You would have also learned in your previous sessions that the blood coagulation system consists of a variety of procoagulant and anticoagulant proteins which are normally present in the blood. However, normally the anticoagulants predominate and the blood does not clot because that would obviously impair the normal flow of blood. This mechanism whereby there is a delicate balance between the procoagulant and anticoagulant activity in the blood is part of the homeostasis, which is maintenance of constant internal body environment. So the anticoagulants normally predominate. However, following injury to a blood vessel, external injury, or damage to the internal damage to the cardiovascular system, the blood coagulation system is activated through two pathways. The extrinsic pathway, which is short-lived, is initiated earlier and is related to external injuries to the blood vessels. The extrinsic pathway following tissue damage leads to release of tissue factor which activates factor 7, and then ultimately it leads to activation of factor 10. Similarly, internal damage to the cardiovascular system leads to activation of the intrinsic pathway, which is generally slower to activate but has uh, a longer duration of action. Uh, it leads to activation of various blood coagulation factors, namely factor 12, 11, 9. You don't have to remember all these steps. What you need to remember is that extrinsic pathway is uh, triggered by tissue damage, whereas the intrinsic pathway is triggered by internal damage to the cardiovascular system, and both pathways converge at the activation of factor 10. So that is where the common pathway starts. Uh, so activation of factor 10 leads to activation of prothrombin, which leads to activation of thrombin, and activated thrombin acts on fibrinogen. Now remember, all these blood coagulation factors are normally present in the plasma in an inactive form. So activation of thrombin acts on fibrinogen to convert it into a polymer. Remember, fibrinogen is one of the plasma proteins. So you've got albumins, globulins, and fibrinogen. Fibrinogen is present in the smallest amounts compared to other plasma proteins. So once fibrinogen is activated, it polymerizes to form the fibrin polymer, which is a cross-linked form of fibrin, and that is what a blood clot is composed of. So remember these pathways because we shall be referring to these when we discuss various blood thinners. You may also find it quite useful to have a basic understanding of various uh, tests which are used to evaluate the hemostasis, including the bleeding time, prothrombin time, INR, activated partial thromboplastin time, thrombin time, and then estimation of various coagulation factors. So again, I'm not going to read everything, but just give you an example that bleeding time is basically the time interval between oozing of blood from the time of injury to the arrest of bleeding, and it basically measures the platelet function in vivo. And the normal values are 2 to 9 minutes, and you would expect the bleeding time to be prolonged in uh, platelet deficiency, for example, thrombocytopenia, and in von Willebrand disease, which we shall discuss later. Obviously, the anticoagulant drugs, for example, will not directly affect the bleeding time. Similarly, you would be familiar with the INR. We've discussed that before in another plenary, which is basically the prothrombin time of the patient compared to a control. And again, it is prolonged in uh, deficiencies of factor 7, vitamin K, liver disease, and with warfarin therapy. So you can read about these tests and then also remember that estimation of the blood levels of various coagulation factors may be required in disorders related to specific coagulation factor deficiencies. For example, factor 8 deficiency in hemophilia would be indicated by low plasma levels of factor 8. Similarly, low factor 9 levels would be indicative of Christmas disease. So you can read more about these to understand the description, normal values, and interpretations of different blood tests which are used to evaluate hemostasis. Increased risk of bleeding, uh, broadly speaking, can be associated with three main causes: medical conditions, surgical trauma, and local pathologies. Medical causes may be related to blood vessel wall defects such as disorders of collagen synthesis, such as Marfan syndrome and then Ehlers-Danlos syndrome. These are quite rare and you're unlikely to come across these in practice, so I'm not going to discuss them in detail. Platelet disorders are relatively more common and include both deficiency disorders as well as functional disorders of platelets. Coagulation disorders related to deficiencies of various coagulation factors, and then finally drugs, including both antiplatelet drugs such as aspirin, clopidogrel, dipyridamole, etc., and anticoagulant drugs such as warfarin, apixaban, rivaroxaban, dabigatran, and we've covered the antiplatelet and anticoagulation drugs uh, in a separate plenary which you can look at. Then surgical trauma may be related to the operative procedures you are undertaking. And finally, local pathologies such as local inflammation uh, can increase the risk of bleeding. You would observe that if there is gingival inflammation and you were to carry out a scale and polish, obviously you're likely to experience more bleeding. That's why we provide oral hygiene advice prior to operative treatment to minimize uh, local inflammation in the gingival tissues. And very rarely there may be vascular malformations associated with the jaws, which can increase the risk of bleeding. And we shall discuss each one of them in a bit more detail in the next slides. Before discussing specific diseases related to uh, platelet disorders and blood coagulation disorders, just a few words about uh, general features of uh, bleeding disorders. Bleeding could be local, that is, it is restricted to a specific site in the body, or it could be general, that means any organ system could be involved. Also, bleeding could be spontaneous, that it occurs without any obvious trauma or injury, or it could follow injury or trauma or surgical interventions. Obviously, you would expect bleeding even in a healthy patient, but we're talking about more severe bleeding, which is difficult to control with routine measures. Platelet disorders generally present with bleeds in the skin and the mucosa, so the bleeding is more superficial, whereas with coagulation disorders, uh, bleeding is uh, in deep in the joints, muscles, or internal body organs. Uh, when you observe bleeding, excessive bleeding in your patient uh, from a wound following injury or from surgical interventions, uh, immediate excessive bleeding is usually indicative of platelet disorders, because you would remember from what we discussed earlier that the initial arrest of bleeding is dependent on the formation of a platelet plug. So if the platelet plug fails to form, there would be immediate excessive bleeding. Whereas if bleeding is caused by a coagulation disorder, there may be a false sense of hemostasis initially due to formation of a platelet plug, only to be followed by more severe bleeding, because you would remember that a platelet plug needs to be stabilized by cross-linking of fibrin following activation of the clotting cascade. So if a blood clot does not form, the platelet plug is not going to maintain hemostasis for long. So the initial arrest of bleeding would be followed by more severe bleeding. So for this reason, if you have patients with platelet disorders and you manage to achieve hemostasis, then hopefully the blood clotting cascade would lead to a stable blood clot formation and stabilize uh, the arrest of bleeding, so you do not need to worry about too much. However, if you have patients with coagulation disorders or patients who are on anticoagulant drugs, the initial arrest of bleeding may be misleading. So you need to observe these patients for slightly longer before you discharge them from your practice, just to make sure that a stable blood clot has formed, whatever local measures you have adopted to stabilize hemostasis. So this is an important point from a clinical standpoint. So first we'll discuss platelet disorders which lead to increased bleeding tendency, and platelet disorders may be related to deficiency of platelets, which we call thrombocytopenia. Penia is to do with deficiency, and thrombocyto means to do with platelets. So thrombocytopenia or reduced platelet counts may be due to impaired production as observed in leukemia, which is a type of white blood cell cancer, but also affects the production of platelets. Aplastic anemia, where there is deficiency of all blood cell types, including RBCs, WBCs, and platelets. So it can be inherited or it can be acquired. For example, damage to the bone marrow following radiation therapy or certain antibiotics and cytotoxic drugs can lead to aplastic anemia, and you can read more about it. This is not within the scope of this session to discuss all these disorders in detail. Megaloblastic anemia, you would know that deficiency of vitamin B12 and folic acid can lead to megaloblastic anemia because these nutrients, vitamin B12 and folic acid, are required for reproduction and maturation of blood cells. Although it primarily affects the RBCs, but the same nutritional factors are also required for production and maturation of platelets. So it's not unusual to have platelet deficiency in megaloblastic anemia. Myeloma, which is a malignancy involving the plasma cells, can also affect the platelets. Myelofibrosis is a form of malignant change in the bone marrow, which can lead to impaired production of all blood cell types. Marrow infiltration from adjacent tumors, because remember that bone marrow is the main site of hematopoiesis in adult life, and infiltration of bone marrow by solid tumors can lead to impaired production of blood cell types, including platelets. Finally, certain drugs such as cotrimoxazole and cytotoxic drugs can damage the bone marrow and lead to impaired production. So the first type of thrombocytopenia is due to impaired production, which in turn can be related to all these causes. The second category of thrombocytopenia is related to increased destruction of platelets, the commonest one being autoimmune thrombocytopenic purpura or idiopathic thrombocytopenic purpura, a disorder in which the immune system destroys the platelets. It can be seen in children as well as adults. The term purpura basically means purplish discoloration of the skin due to bleeding underneath the skin or mucosa. So that's the commonest one. Secondary immune-mediated damage to the platelets can also be observed in systemic lupus erythematosus, HIV infection, and chronic lymphatic leukemia. Moreover, you would know that platelets have a short half-life, on an average 8 to 12 days, and if blood is stored for long periods of time, stored blood can be low in platelets and can lead to what we call the post-transfusion purpura. That is, following a blood transfusion, uh, a patient may develop purpura due to platelet deficiency because stored blood is low in platelets. Finally, elderly people may show signs of thrombocytopenia, something we call senile purpura. So these slides show how purpura manifests clinically. You can see the image of an elderly woman, and they have developed skin purpura following a tooth extraction, because in elderly people there could be relative deficiency of platelets, plus their skin is quite loose, so purpura manifests quite remarkably. And it doesn't have to be tooth extraction. The same could happen with minimal trauma to the face or the skin, or other operative interventions. And small amount of bleeding into the soft tissues can lead to uh, quite an extensive patch of purpura on the skin. So all you need to do is ensure that there is no active bleeding. You get their most recent blood counts through their GP and reassure them if there is no active bleeding, no immediate intervention is required. A well-recognized inherited disorder of platelets is von Willebrand disease, which is caused by reduced level of factor VIII von Willebrand fraction. Now remember, blood coagulation factor VIII has two components: the von Willebrand fraction, which participates in platelet adhesion, so it promotes platelet adhesion uh, as part of formation of the platelet plug, whereas factor VIII C fraction, the coagulation fraction, contributes to blood coagulation cascade. Um, and these deficiencies of these two fractions are two distinct disorders. Deficiency of von Willebrand fraction behaves like a platelet disorder, whereas deficiency of factor VIII-C behaves like a coagulation disorder, or what we call hemophilia A. And we'll discuss that in the next section under coagulation disorders. So, reduced level of factor VIII von Willebrand fraction lead to defective platelet function. It is normally inherited as an autosomal dominant trait, therefore it can affect both males and females, whereas hemophilia A is inherited as an X-linked recessive trait, therefore it affects the males only. Because it's a defective platelet function, it can lead to skin bleeding, purpura involving the skin and mucosa, just like thrombocytopenia, and it is characterized by a prolonged bleeding time. In terms of laboratory diagnosis, uh, there would be evidence of low factor VIII von Willebrand fraction levels, whereas the factor VIII C fraction would be normal. And von Willebrand disease is managed by uh, platelet replacement therapy, or with the use of desmopressin, which is a synthetic analog of antidiuretic hormone. You don't need to know all that, but you do need to have a basic understanding of von Willebrand disease, that whilst it's related to factor VIII deficiency, it's just the von Willebrand fraction, and factor VIII-C deficiency is a coagulation disorder, which we call hemophilia A. I'm just going to mention some inherited disorders of platelet function. So these are functional disorders. Uh, you're not going to come across patients with these disorders because they're quite rare and managed under specialist settings. So it's primarily for academic interests only. Bernard-Soulier disease is basically large platelets which fail to adhere, and Glanzmann's thrombocythemia is normal sized platelets but they fail to aggregate. So these are two inherited disorders of platelet function. In addition, there could be acquired disorders related to drugs, something which we've covered uh, in a separate plenary. So drugs which can affect platelet function and are used routinely in patients with cardiovascular disease, you should know them by now. So aspirin, clopidogrel, dipyridamole, perusogrel, and ticagrelor. And there's a full guidance available on the PDSC website on the management of patients on antiplatelet agents. So I would encourage you to read the guidance. Uh, Excessive alcohol intake can impair platelet function. And finally, increased blood levels of urea, which we call uremia, can also impair platelet function. And also remember that patients who develop uremia can develop severe inflammation of the oral mucosa, something we call stomatitis, which can be accompanied by fetor oris or halitosis, as well as mouth ulcerations. In regards to dental and surgical management of patients with thrombocytopenia, just remember that the normal platelet count ranges between 150 to 450,000 per microliter, and for dental and minor oral surgical procedures such as tooth extractions, uh, periodontal treatments, a minimal platelet count of 50,000 per microliter is required. So if you have a patient with a history of thrombocytopenia, the first thing you need to do is liaise with their GP and get their most recent platelet counts. And as long as they are above 50,000, you can carry out simple dental procedures and uh, minor oral surgical procedures such as tooth extractions under local anesthesia. Obviously, if you're doing a full mouth scale and polish, you would want to work in one quadrant, working on a few teeth, ensuring that you are able to achieve hemostasis before moving on to the next quadrant. For major surgery, obviously, you're not going to perform major surgery. That would be done by the specialist who would determine the platelet counts and the implications. But so that you know that for major surgery, a minimal platelet count of 75,000 per microliter is required. And if the counts are below this value, replacement therapy can be used to raise the platelet counts. There are various options for replacement therapy for deficient platelets. Uh, Patients can be provided platelet-rich plasma or platelet-rich concentrates. You don't need to worry too much about it, but I've just included it here, so if you're interested, you can read more about it. Disorders of blood coagulation may be classified as inherited disorders or acquired disorders. The most well-recognized inherited coagulation disorder is Hemophilia A, which is due to the deficiency of factor VIII. Uh, Christmas disease, deficiency of factor IX. Um, Other clotting factor deficiencies such as deficiencies of factor 5, 10, 12, and then also deficiency of fibrinogen, referred to as congenital afibrinogenemia. The most recognized inherited coagulation disorder is hemophilia A, which is due to the deficiency of factor VIII. And as we've discussed, that factor VIII has two components. One is to do with coagulation, which we call the factor VIII-C, and the von Willebrand fraction, which is to do with platelet adhesion. The deficiency of factor VIII-C is responsible for the coagulation defects seen in hemophilia A. It's transmitted as an X-linked recessive disorder, which means it primarily affects the males, whereas all daughters of the affected males are potential carriers. Positive family history can be seen in 65% of the cases, and hemophilia A is 10 times more common than hemophilia B, which we'll discuss next, except in India, where the frequencies of hemophilia A and B are nearly equal. Uh, because of the associated risks, all hemophilics in the UK are to be registered, so that they can be managed appropriately. Uh, and we'll discuss some of the relevance to dentistry in the next slides. The clinical presentation of hemophilia A and the associated complications are related to the uh, magnitude of deficiency of factor 8. If the levels are below 1% of the normal levels, there is a risk of frequent spontaneous bleeding from early life, hemarthrosis, that is bleeding into the joints, and bleeding into the muscles. Levels 1 to 5%, there is severe bleeding following injury and occasional spontaneous bleeding. However, if the affected individual has uh, factor 8 levels between 5 to 25%, they can lead a relatively normal lifestyle and may remain undiagnosed. The major concern is post-traumatic bleeding. So not all hemophilics have the same severity of disease. That's what you need to understand. And it depends on the magnitude of factor 8 deficiency. Hemophilia can have a variety of manifestations clinically. It can present as an acute abdomen due to abdominal hemorrhage. There could be bleeding into the cranium, which can be potentially fatal. Bleeding stops initially, only to be followed by intractable blood loss after an hour or more. Now, the reason why the bleeding stops is, you got to think, why does the bleeding stop initially? Because if the platelet function is normal and a platelet plug forms, that would cause initial arrest of bleeding. However, the platelet plug is not functional and structurally strong enough to arrest the bleeding long term, and you need a blood clot. And because in hemophilia, a blood clot may fail to form, that is why there is delayed bleeding. And that's something we will discuss more in the context of differentiation between platelet disorders and coagulation disorders. And the other thing you need to remember is that once the bleeding starts, it cannot be controlled by pressure alone. Clots may form but have no hemostatic effect. So these are some of the manifestations of hemophilia, and we've already talked about the risk of bleeding into the joints, hemarthrosis, and bleeding into the muscles. The laboratory diagnosis of hemophilia, like any other coagulation disorder, is based on a full clotting screen, which includes the bleeding time, the prothrombin time, the activated partial thromboplastin time, and also the estimation of clotting factors in the blood plasma. So in hemophilia, you would expect a normal bleeding time, a normal prothrombin time, but a prolonged activated partial thromboplastin time. Also, the factor 8C levels in the blood plasma would be low. However, the von Willebrand fraction of factor 8 levels would be normal. Now, patients requiring surgical treatment uh, are managed under the care of a hospital-based hematologist, and you're unlikely to be treating hemophilic patients in primary care. But just for the sake of your understanding, uh, hemophilic patients requiring operative surgery, how they are managed, they need to undergo a thorough preoperative assessment. They're admitted to the hospital and have their full hemostatic screen, including routine blood tests and a full clotting screen. They would also have specific antibody assays to determine if there are any antibodies to factor 8 or other clotting factors. They would also have their liver function tests, their Hep B, Hep C, HIV tests. Because of frequent blood transfusions, previously many hemophilics contracted these blood-borne infections. Fortunately, the incidence has been minimized now, but still you need to make sure that they are not carrying any blood-borne viral infection. They would also have a group and cross match where their blood sample would be taken and matched against uh, a donor's blood just in case there is need for a blood transfusion during surgery. They would also have all their preoperative investigations, including relevant radiographs. And this is the bottom line. All surgical procedures are to be covered with anti-hemophilic factor, which is factor 8, 1 hour preoperatively, because the half-life of anti-hemophilic factor is roughly 12 hours. So a preoperative cover of factor 8 is provided to all hemophilics depending upon the nature and duration of surgery, uh, and then this is continued post-operatively. Some considerations for providing anesthesia to hemophilic patients. Obviously, anesthesia is administered just prior to the surgery and also requires uh, appropriate cover of factor 8. So never operate without appropriate cover. It is best to avoid regional anesthesia, endotracheal intubation, which is usually done for general anesthesia, and intramuscular injections. All of these should be avoided. Uh, when we say regional anesthesia, you got to apply it to the oral cavity. So you would want to avoid uh, an inferior alveolar nerve block, for example, which is a type of regional anesthesia in the oral cavity. And it is preferable to give infiltrations. And with the availability of articaine, you can provide infiltrations for invasive treatments on the lower molars. So, for example, deep fillings, etc. All forms of periodontal treatment can be managed with infiltrations alone, with articaine without the need for a nerve block. And this is not only applicable to hemophilia, this applies to all patients with increased risk of bleeding, whether due to platelet disorders, coagulation disorders, or antiplatelet anticoagulation drugs. So it's best to restrict yourself to infiltrations, uh, and even in the mandibular molar region and premolar region, you can manage most restorative and periodontal treatments with infiltrations alone. You do not need a regional nerve block. You can also try intraligamentary injections, which is injections into the periodontal ligament space, should the pain control with infiltrations be inadequate. And obviously, sedation is preferable to general anesthesia whenever appropriate. Uh, Ultimately, it will depend upon the nature and duration of surgery. So if the patients need a major surgical procedure, general anesthesia would be unavoidable. However, as I said, these patients are under the care of a hospital-based hematologist, and the surgeon and the hematologist will work together to determine the appropriate level of cover for the patient, both preoperatively and postoperatively, and uh, they can be managed in a secondary care facility. So for invasive dental procedures like tooth extractions, again, you would need factor 8 replacement therapy, on an average 50 to 75% factor 8 level at the time of the procedure. Preoperatively, factor 8 is administered IV along with tranexamic acid, uh, either IV at the time of the procedure or 24 hours preoperatively by mouth. And postoperatively, the patients need to be observed for 3 to 7 days, soft diet, postoperative tranexamic acid, and repeat factor 8 cover if bleeding starts. Now, obviously, as a DTH, you would not be involved in this, but so that you understand how these patients are managed for tooth extractions in the hospital settings. Tooth extractions for hemophilic patients are to be done in a hospital setting, uh, and you would need some additional precautions such as minimizing hard and soft tissue trauma, uh, not raising surgical flaps in the lower molar region, particularly lingual flaps. Uh, the sockets may need to be packed with artificial clotting materials such as Surgicel or gel foam, Again, for extractions in any patient with increased risk of bleeding or coagulation disorders, uh, the extraction sockets need to be packed with appropriate artificial hemostatic agents such as Surgicel or gel foam and a horizontal mattress suture placed against the extraction socket. Uh, Acrylic splints may be used if multiple extractions are to be undertaken, and careful mouth toilet post-operatively, possibly using tranexamic acid mouthwashes, which we'll discuss later. Obviously, you're not going to be involved in maxillofacial surgery. However, just for the sake of your understanding, for major surgery, including maxillofacial surgery, the factor 8 level of hemophilics needs to be raised up to 100% at the time of operation and then maintained above 50% for 7 days post-operatively. Preoperatively, factor 8 is administered IV, and post-operatively, the patient is kept in the hospital for up to 10 days, soft diet, and factor 8 given IV Bisendai, which means 12 hourly for 7 to 10 days, and then they are maintained on their normal regime of factor 8. The second most common inherited coagulation disorder is factor 9 deficiency or Christmas disease, also known as Hemophilia B. It is also transmitted as an X-linked recessive disorder like Hemophilia A and may be indistinguishable from classic hemophilia, which is Hemophilia A. Diagnosis is dependent on the hematologist evaluating the levels of factor 9 and factor 8 in the blood plasma. Uh, Treatment like for factor 8 deficiency in hemophilia A, you provide replacement therapy. Likewise, in Christmas disease, treatment is mainly based on factor 9 replacement. Um, the oral management for hemophilia B is very similar to hemophilia A. So all the measures we've discussed in preoperative assessment, precautions, replacement therapy with factor 9, management in a hospital setting, and then for oral and dental treatments, avoiding nerve blocks and relying more on infiltrations, using local hemostatic measures. Those are the things which need to be done as part of uh, their oral management. So, in addition to the inherited coagulation disorders, acquired coagulation disorders are well recognized. The most important one being related to liver disease. You would know from your knowledge of physiology that liver is the site for synthesis of coagulation factors, and in the presence of liver disease, uh, synthesis of coagulation factors may be impaired, leading to a severe bleeding tendency, which can be potentially fatal. So, when you see patients with a history of liver disease, uh, do not simply rely on their, word. Don't take their word that they are doing fine and there are no issues. Whilst that is important, it is equally important that you liaise with the patient's medical practitioner and inquire about any recent liver function tests, any recent coagulation screens if they were done, and if not, then depending upon the nature of your intervention, you can ask for these tests. Do not hesitate to ask for these tests because bleeding due to liver disease can be very serious and life-threatening. Uh, Vitamin K deficiency, as you would know, many blood coagulation factors require synthesis. For their synthesis, they require vitamin K. So blood factors such as factor 2, 7, 9, and 10 are dependent on vitamin K. So that's what we call vitamin K dependent blood coagulation factors. And these are the same factors which are targeted by uh, drugs like warfarin. So any history of vitamin K deficiency can lead to severe bleeding tendency. And finally, drugs, anticoagulant drugs, which we'll discuss in the next slides. Apart from inherited and acquired disorders of blood coagulation, uh, hemostasis may also be impaired by anticoagulant medications. We've already discussed this topic in a separate plenary. However, I've just included it here for the sake of completeness. Various anticoagulant medications such as warfarin, which is the most commonly used anticoagulant, dabigatran, rivaroxaban, apixaban, and heparin may impair blood coagulation, warranting additional precautions when undertaking invasive procedures in patients taking these medications. A full guidance on oral surgical management of patients on anticoagulant medications is available at the PDSC website. Obviously, as dental therapists and hygienists, you would not be undertaking extractions in adults, uh, and you would be mainly concerned about uh, periodontal procedures, which may increase the risk of bleeding. And we shall discuss the precautions and local measures in patients on anticoagulant medication in the later slides. Local causes of bleeding include surgical trauma to the soft tissues as well as to named blood vessels in the oral cavity. Uh, Soft tissues is particularly relevant to you as a DTH. You would have observed that when providing operative treatment to patients with acute gingivitis, the tissues tend to bleed more profusely due to acute inflammation, and you should take appropriate measures to minimize inflammation before you undertake operative periodontal treatment. Um, if there is injury to named blood vessels in the oral cavity, particularly the greater palatine artery, which accompanies the greater palatine nerve, the nasopalatine artery, which accompanies the incisive branches of the maxillary nerve, and the inferior alveolar artery, which accompanies the inferior alveolar nerve into the mandibular canal, when undertaking particularly surgical extractions, for example, or performing bone surgery. If these vessels are injured, for example, from uh, a burr during drilling of the bone, that can lead to significant bleeding. However, you are unlikely to encounter uh, such scenarios because you wouldn't be operating uh, on the bone or removing bone or undertaking surgical extractions. So it is beyond your scope, but I've just mentioned it just for the sake of, uh, completeness of the topic. Otherwise, you're unlikely to encounter uh, injury to blood vessels during the operative treatments you perform. So your main concern is bleeding from the soft tissues, particularly when they are inflamed. Bleeding may also be related to local pathological lesions in the oral cavity, including both soft tissues and bone. The commonest one you're going to see would be a pyogenic granuloma, which is a reactive lesion uh, involving the gingivae. It can also be seen in pregnant ladies, where it's referred to as a pregnancy tumor, and it has a strong tendency to bleed with minimal manipulation. Hemangiomas are vascular malformations uh, involving the soft tissues, usually seen on the lips or the cheeks, and obviously you're not going to deal with those. Finally, there can be vascular malformations within the bone, and they usually appear as multilocular lesions. So where you have a suspicion when you're extracting deciduous teeth, if you identify anything unusual on the radiographs, it may be best to refer um to get a second opinion from a specialist, because vascular malformations, although rare, can cause significant and potentially fatal bleeding. As we've seen, there could be a variety of medical and local causes of increased bleeding, and your job as a DTH professional is to recognize medical conditions which increase the risk of bleeding during operative procedures. And likewise, on clinical examination, you need to identify any local findings in the oral cavity which may increase the risk of bleeding, and then determine the need for referral of more complex cases or more risky cases to specialist colleagues. So that's your main job, um, where you are going to undertake operative procedures and the patient has a slightly higher risk of bleeding, either because of a pre-existing medical condition or due to any medications they might be taking uh, for their medical conditions. It might be best to plan the procedure in multiple stages. And it is best to, for example, if you are to undertake extractions of two deciduous teeth, you would first remove one tooth, achieve hemostasis before you move on to the next tooth. Similarly, if you are going to do a full mouth scale and polish, it might be best to work on a few teeth in one quadrant, achieve hemostasis, ensure that the bleeding is manageable with the precautions you've taken before you move on to the next quadrant. So that is always good, and you would do everything to minimize surgical trauma. You would do that for every patient anyway. However, you need to be extra careful when treating patients with increased risk of bleeding. There are additional hemostatic measures you can take. I would say use of local anesthesia with vasoconstrictor remains the most practical measure you can take to minimize bleeding, particularly from the gingival soft tissues. So if you infiltrate uh, local anesthesia with vasoconstrictor, particularly transseptal injections are quite helpful, where you inject directly into the attached gingivae. Uh, Obviously, that can be a lot more uncomfortable for the patient, so make sure you've anesthetized the area appropriately before you do your transseptal injections, and that would have a significant impact on reduction of bleeding. Use of hemostatic periodontal dressings is another option, and we'll discuss these in the next slide. Also, use of electrocautery or silver nitrate sticks to minimize bleeding from the gingival soft tissues is an option. Uh, and finally, uh, if you're based in a hospital, you may have access to tranexamic acid mouthwashes. So as you would know, tranexamic acid is an antifibrinolytic agent. So it basically prevents lysis of a blood clot and stabilizes it. It's usually prescribed as a tablet or injection, but what many oral surgery units do is they ask the pharmacy to prepare a mouthwash, which is basically tablets of tranexamic acid dissolved in water, and patient can use it as a mouthwash post-operatively, say for example, following multiple extractions. However, you are unlikely to use it in primary care, but so that you know that it is an option, which is obviously restricted to secondary care in the UK. There are a variety of periodontal dressings which can be used to achieve hemostasis from the gingival soft tissues uh, and aid healing. Uh, a popular one is Copac, which is basically a eugenol-based dressing, which comes as a two-paste system. You mix the paste, and once it's in a doughy consistency, you adapt it to the gingival soft tissues, and it hopefully sticks for a few days and reduces bleeding from the gingival soft tissues. Another one is Septopack, which is widely available in the UK. It is basically uh, a semi-solid type material which you knead within your fingers with your fingers, and you can simply adapt it onto the gingival soft tissues to minimize bleeding and aid healing. You would not normally use them, but so that you know that these periodontal dressings can be used to aid hemostasis. Bleeding from the gingival soft tissues can also be minimized with the use of electrocautery, which is basically an equipment which utilizes electric current to heat the tissues to achieve hemostasis. Obviously, you would need the right equipment and training in your practice to use it. Uh, a more handy way might be use of silver nitrate sticks, which you simply pick one of these, stick it into the gingival soft tissues where there is bleeding, and that is going to chemically cauterize the tissue with silver nitrate, and that would minimize bleeding. So these are just the options. How frequently you're going to use them, probably not very frequently, but so that you're aware. And then also laser light can also be used to minimize bleeding from the gingival soft tissues. I would suggest two resources for consolidation of your knowledge on these topics during your self-directed learning. Scully's Handbook of Medical Problems in Dentistry, and you can read the relevant sections in the book. This isn't the full text of Scully, which is quite hefty. This is a more of a smaller version, and you might find more concise information here. And also the Scottish Dental Clinical Effectiveness Program STCEP guidelines on management of patients taking anticoagulants and antiplatelet drugs, which is available on the STCEP website.